Good morning, PT on Ice. My name is Dr. Britt Lademann. I'm on the spine team and I teach total spine thrust manipulation. This morning, what I want to do is talk through some of the updates the literature has provided us over the last even 5 to 10 years on how to manage concussions. And what I'm hoping for is just the everyday PT in the clinic who maybe sees some concussions filter through various referral sources, or maybe discovers a concussion symptom going on in a patient that might be more chronic. What's kind of the bare minimum things we should be assessing, and what has shifted recently in the research to update our concussion management? So I understand that most of y'all are probably in a clinical setting and not running onto a field immediately after a sport concussion. And to be honest, most of my patients that I see who have concussions are walking in that subacute to chronic phase. In the adult population, we see a lot of these persistent concussion symptoms in our MVA patients. So this is something we should always be screening for, and it's out there, and it's probably way more common than we think. And I want to give us a little update on how we've been thinking about concussions historically and how we should shift our perspective. So right off the bat, one of the big updates we've discovered through over the last 10 to 15 years, an increase in funding and research and concussion research, is what's actually happening acutely, and how we're describing what's happening to patients should probably change. Historically, we've come from this perspective of the brain bouncing around inside the skull, a brain bruise, this very mechanical explanation, and then maybe treatment approach to what's happening. We still don't know all of the things that happen when the brain is undergoing an impulse and a trauma. One of the things we've noticed through research is because there's different densities in brain tissue, gray matter, white matter, different densities, when there's an impulse to the system, we see this mechanical friction happening because of the physics of two different density tissues kind of frictioning against each other. What happens is this big barrage of signaling, excessive signaling that happens. And the way that they've described it in the recent consensus statement on concussions is this neurotransmitter and metabolic cascade that begins to happen up in the brain. The net result of this is essentially an energy crisis. We see a huge drop in ATP over the next 7 to 10 days after a concussion. So what this does to our brain is we have fluctuating varied symptoms and fluctuating ATP stores in the first several hours to first few days. Then the ATP storage capacity in our brain actually steadily dips and bottoms out at about the 7 to 10 day window. This is when we're most vulnerable to that second impact, because our brain has much less capacity than normal to handle overload. And that could be mechanical overload, certainly, but also cognitive overload. How this should shift our description of what's happening to patients is, one, we might not necessarily see the worst symptoms manifest until several days after a concussion. So we should not rate the intensity of the concussion based on the first few days, and we should be educating our patients if we do see them acutely, hey, I'm expecting you to actually feel worse over this next week. If we are managing someone acutely, we do want to recommend that in that 1 to 2 week window, we avoid any direct contact that could be that second impact. But typically what we want to shift, in most of our population, what we want to shift our education on is what we should be doing in that first week. So historically, we've recommended, and this was still in the consensus statement, the international consensus statement for concussion management back in 2016, the recommendation was still immediately after concussion, isolate yourself, find that quiet, dark room, avoid any overstimulation, and this is actually shifted. So they've updated this recommendation. We're now no longer recommending that complete rest or that cocooning no more than 72 hours after a concussion. What we found is if we do engage in more activity and get back to normal everyday things sooner in that first week, we actually see reduction in symptoms long-term and a decreased likelihood of that persistent concussion. Once we dip out of that 7 to 10 day window where our ATP stores are the lowest, our ATP storage capacity in the brain will steadily climb back up, but it doesn't get back to baseline until about 22 to 45 days. So when we're talking to people about, hey, when should we be getting back into full return to work, full return to school, back to sport, we're not going to have that full capacity in our brain for several weeks to months. So this should shift how we're educating people on return to activity. And then the next big thing we want to do is really encourage people in that time period to be active. The recommendations are, even in that first week, get up, engage in the world around you, light activity, light cardio. We want to stay in a sub-symptom threshold, which means we're allowed to flirt with symptoms. We do not want to trigger symptoms that last more than an hour. And we're trying to have a majority of our movement, exercise, engagement keep us below that symptom threshold. The other big key we want to emphasize in that first 1 to 2 week period is sleep. And this is incredibly important throughout the arc of recovery, but especially because our brain is operating at decreased capacity in that first 1 to 2 weeks. So 2 big shifts in how we're thinking about early concussion management. We don't want our patients to cocoon. We don't want to isolate a brain at lower capacity, often with many cascading symptoms. That's when people can really become more depressed. That can exacerbate their emotional symptoms, and it delays recovery. And then we want to really use a graded exposure approach to ease them back into activity. Okay, so that's acute concussion updates. No longer cocooning patients, getting them engaged early with movement, and educating them on what's actually happening in the brain. This isn't just a bruise. We're dealing with an energy storage crisis, and we need to wait long enough for those energy stores to get back to baseline. Most of the people I see, however, are not in that acute symptom management. Most of them in the adult population are, I had an MVA 3 months ago. I've been at maybe a chiro clinic getting a more symptom level modality grade management of my symptoms, may or may not be exercising or easing back into activity early. So everyone who has first points of contact in the healthcare system needs to be aware that we need to educate patients on early return to activity. Now, when these patients roll into my clinic, typically they've been dealing with these concussion symptoms untreated for months. So that's that subacute phase. That's that persistent concussion symptom or syndrome. We're no longer calling it post-concussion syndrome patient. What we should be screening. So everyday clinician, the number one resource I recommend is grabbing the updated SCOTE-6. What this is the sport concussion, a clinical assessment tool. And what it does is it walks you through the bits and pieces of the exam that are most vital to collect data on for a patient with concussions. This also has a very important piece to it. This is a symptom score sheet that'll come with that SCOTE-6. It's incredibly important. Number one thing you want to take away from this podcast, incredibly important to track symptoms and symptom intensity. Just sitting down with the patient and walking through the symptom list, which is anything from headaches, pressure in the head, neck pain, sensitivity to light, feeling like you have difficulty concentrating, irritability, excessive sweating. Some of these symptoms the patient might be dealing with and have no idea it's related to their concussion. So this is a very validating, sometimes emotional thing to look at all those symptoms and just start to rate them. This really helps the patient, oftentimes who are struggling to even find words for everyday things, articulate what they're feeling. When you have a patient come in, you have to establish irritability early, because that will tell you how to dose the examination component over the next several visits. So once we know irritability, we'll know how much can I dig into potentially triggering symptoms, provocative tests, or even just conversation. We don't want to flare our patients up to the point where they're going to have a crash the rest of the week. So gauge irritability early. And then the SCOTE-6 will walk you through what components should we be testing early on. What I recommend in the first 1 to 2 visits is grabbing a balance baseline measure. A mini best is great. So single leg, double leg, tandem stance, time it out. That's a great test, retest over time. In our lower irritability patients, we can add a dual task component to that. And then a couple other metrics important early. We need to screen cervical. There's a ton of crossover with cervicogenic symptoms and vestibular symptoms in concussions. So screen cervical spine. And then we want to grab VOMS testing early as well. And that's a little bit more triggering. So if you're going to do some VOMS testing, which will look at saccades, look at head turns, look at eye tracking, convergence, because that tends to be most triggering, we want to have that closer to the end of the exam. That's likely going to flare people up. And I recommend only a couple of these tests, especially in that first eval. If I have a very high irritability patient, oftentimes all we're doing in that initial eval is getting a little bit of the story, a little bit of the goals, and then rating symptom scores. And if that's already pushing the patient to capacity, we're going to send them home with this symptom tracking sheet or use an online tracking app to log symptoms over the first 2 weeks. This data collection portion is vital. This is where you get to see the map of a patient's week. What are their triggers? What does that crash look like? And that will guide your patient education on how to pace activity. The next key with a lot of these patients is baking in recovery time. What we want to do when we trigger symptoms is let them get back down to baseline. This is an education component that's really important that you should reinforce multiple times throughout your treatment. Other things we want to screen over the next few sessions, oftentimes we see orthostatic sensitivity in these patients. So lay down for 2 minutes, heart rate, blood pressure, stand up for 1 minute, heart rate, blood pressure, and symptoms. Track that over time. That will help us know, hey, are we going to have issues getting back to work or sport where we have big position changes? And then recall is the other thing that we want to grab a data point on, okay? Numbers tend to be harder for people than words or numbers. You want to wait 5 minutes in between, give them a list, 5 to 15 words or numbers, then they need to recall it. That is also something we should test, retest, and that is also something that can be a little bit triggering. So those are the highlights, and again, that SCOTE 6 will walk you through some of those highlights of key exam points to take in the first few sessions. Once we transition out of that early assessment phase, what concussion management looks like in physical therapy is what it can look like for a lot of different conditions, including persistent pain, where we want to treat it holistically. We want to consider inflammatory factors, sleep, stress, and often lurking underneath some of these symptoms is depression and anxiety, and this cluster of symptoms that can almost present like hyperactivity, ADHD. Sometimes these patients will go on meds for those symptoms, and sometimes that is the biggest lever we can pull early on when someone can't progress and is overloaded and flared consistently. So important to triage and refer out when necessary, and often that mental health component is a big piece of the pie, especially with persistent symptoms. We'll take this graded exposure approach and ease the patient back into cardio, very important, and resistance training, scale them back into their goals. And then I would recommend only 1 or 2 of those more triggering kind of drills at home. Maybe it's recall, maybe it's convergence training, or head motion or eye tracking. Pick 1 or 2 key triggers that are still getting symptoms. Those are homework assignments. You kind of titrate that out based on the irritability, either daily or every other day, and then ease them back into activity. So a couple key updates that I want you to think about is, let's use this update. This is 2023, this SCOTE 6. Very helpful for easing people back into work and sport. And then if you want to dive into more of the updates, this consensus statement in 2022 that came out, again, it's all the experts internationally coming together with some key recommendations and updates on terminology, definitions, and research. There's some really cool stuff in there about prevention. Definitely would recommend that read. So those are the 2 resources I recommend the everyday clinician grab if we're starting to see some concussions filter into the clinic. Last thing, y'all, this is a hugely underserved patient population. Nobody owns this well in the healthcare sphere. We do have some specialty groups, some specialty neurology groups training patients. They're hard to get into. The access just isn't there. Physical therapy is the best place, whether we are acute or chronic, to process, understand, and ease people back into activity with concussions. We should be owning this. This is a huge untapped market, and everybody here has the skills needed to take patients through concussion management, and we can feed it into other physical therapy goals really easily. Okay, y'all, thanks for listening. Reach out with any questions and grab that SCOTE 6 and the updated consensus statement on concussions and have those in your clinic. Have a good rest of your day.